Hello and welcome to our webinar series, Next Steps in COVID-19 Response and Long-Term Care. I'm Andrea Piche, Senior Program Lead at Healthcare Excellence Canada. My pronouns are she and her, and I'm pleased to be your host today. I'd like to start by acknowledging that we're meeting on land that has been inhabited by Indigenous people since the beginning. In particular, we acknowledge that we are broadcasting this webinar from Ottawa, which is the traditional and unceded territory of the Algonquin Nation. We recognize and deeply appreciate their historic connection to this place and the opportunity to gather here today. We are pleased to offer French simultaneous interpretation for this session. If you wish to hear the voice of the interpreter, please select French from the interpretation menu at the bottom of your screen. We invite you to share your questions and comments at any point using our chat box in either English or French. And we encourage all of you to respond to each other's comments and answer questions in the chat as well. We will aim to connect as many of your questions as we can with our speakers during the Q&A session at the end of the webinar. If you need support at any time during this webinar, you can reach out to our tech support using the chat feature. This session is being recorded and will be available on our website in the next couple of days to review or share with colleagues who may have missed it. Finally, we are excited to announce that the next phase of Healthcare Excellence Canada's programming to support long-term care has launched. The application process for Reimagining LTC is open, and you can learn more and apply on HEC's website. We'll also cover off some of the details at the end of this webinar. Today, we're pleased to have Anne McLaren and Micah Asselbergs joining us to talk about ways to build capacity for patient safety in partnership with staff, patients, residents, and care partners. Anne McLaren is a Senior Program Lead for Healthcare Excellence Canada. She's responsible for advancing patient safety through supporting national and regional partnerships and coordinating initiatives such as the Presence of Safety. Anne earned a Master's of Nursing degree from Dalhousie University and has 20 years of experience in healthcare safety and improvement. Career highlights include managing Canada's Safer Healthcare Now and hand hygiene campaigns, and planning and implementing the measuring and monitoring of safety in Canada demonstration and safety improvement projects. Micah is a member of Patients for Patient Safety Canada since 2016. Drawing on personal experiences with the healthcare system and as a volunteer patient partner, she holds the view that partnering with patients can result in safer care and improved health outcomes. In her patient partner roles, Micah draws actively on her professional experience as a leader in the voluntary and health research sectors and as a senior consultant in organizational and public policy development, governance, and planning. Anne, over to you.
Thanks, Andrea, for that introduction. As Andrea mentioned, my name is Anne McLaren, and I am a Senior Program Manager at Healthcare Excellence Canada. I want to welcome you and thank you for attending our session today. I am joining you from Prince Edward Island, which is the traditional and unceded territory of the Mi'kmaq First Nation. In the time that we have together, Mike and I will aim to introduce you to the Presence of Safety, which is the approach to patient safety in Canada that we are promoting at Healthcare Excellence Canada. This approach challenges us to look at safety through a broader, more holistic lens that includes the voice and perspective of staff, patients, residents, and their care partners. Through sharing some of our patient safety history and tapping into the power of patient narratives, we hope to enhance your understanding of patient safety. We want this presentation to be both informative and interactive. We know the foundation of safety lies in curiosity, questioning, reflecting, and sharing. So with that in mind, we hope throughout this presentation, you will take time to reflect on the content presented, ask questions, and if you feel comfortable, contribute to the conversation through sharing your experiences and reflections. The chat box is open. Andrea will be helping to monitor it, and we will have an opportunity for questions and answers towards the end of the presentation. To begin today's presentation, as we do with all of our work in the patient safety world, we want to ground you in the voice of our patients, residents, and their care partners. It is these voices and their experiences that are the driving force behind our mission for safer care. So if we could show that video now.
I know there's patients harmed in the system every day, and my son was one of those harmed. He died as a result.
Within the space of a few years, I lost 7 family members.
I personally had an incident of harm. My son died in hospital following elective surgery. So he was a healthy 15-year-old boy and died from failure to rescue in hospital.
I went in for a surgery. I woke up just as the surgeon was asking for the scalpel, and I was paralyzed. And so I remained paralyzed, but fully conscious for the rest of the surgery.
As you just witnessed through this brief video clip, the power of the patient voice is undeniable. Those of us working in the world of safety and healthcare improvement have long understood and advocated for the inclusion of patients, residents, and their care partners. For close to 20 years, the work that we have done in Canada in patient safety, we've done in partnership with patients, residents, and their essential care partners. Next slide. Our patient safety journey starts with uncovering unintended harm in healthcare. Patient safety is commonly defined as the absence of accidents and incidents. So with that in mind, it makes sense that the majority of our patient safety efforts in the past 20 years have been focused on measuring and preventing unintended patient harm. Globally, we've invested enormous amount of effort in counting how much harm is in our healthcare system. CIHI, next slide, tells us that 1 in 17 hospital stays involved at least one harmful event. The Safety at Home research report, next slide. The Safety at Home research report released in 2013 suggests that 10 to 13% of home care clients experienced an adverse event each year. Next slide. The Canadian Adverse Event Report reported that 7.5% of all hospitalizations in Canada had an adverse event that harmed patients. Next slide. And according to the Risk Analytica report, this is equivalent to a preventable patient safety event occurring in Canada every 1 minute and 18 seconds, and a resulting death every 13 minutes and 14 seconds. Patient safety needs to be a priority for healthcare leaders, staff, patients, and their care partners. Now let's take a moment to look at some of our go-to strategies to prevent harm. I'm sure these will be familiar to most of you. How often have we tried to fix problems by adding in more policies, guidelines, jump to the next slide, and checklists? Next slide. Then on top of that, we layer on safety initiative after initiative to the point where safety becomes a never-ending sea of projects. Next slide. And then we have the strategy of assurance, reassuring our patients, our residents, staff, and leaders that care is safe, and finding ways to explain or dismiss problems and concerns. And next slide. And not a strategy we promote, but one that seems to be on the rise recently, is the blaming and shaming that occurs when a patient safety incident happens, pointing the finger at an individual rather than looking at the failures of the system the individual is working in. Next slide. While many of the initiatives and strategies I've mentioned on the previous slide are important elements to healthcare delivery, they alone are not enough to help move the mark on safety. Despite 20 years of hard work, it's sad to report we've not moved the mark on patient safety. Our rate of patient harm in our system has remained unchanged. we are learning that our top-down, harm-focused approach is off balance and has not been successful in achieving safer healthcare. Our history is teaching us that we need to do something different. Next slide. We are learning that the absence of harm is not the same as the presence of safety, and that measuring failures of the past are not the best predictors of safety today or in the future. Next slide. Some of you may have read our recent blog post titled, "Are we safe or just lucky?" Let's take a minute to reflect on this question. Do measures of harm tell you how safe your care is or how lucky you have been? Can you think of a time when you needed to rely on luck in the absence of safety? When I hear this question, I'm brought back to an incident that occurred in my nursing career. I was working a day shift and was assigned to float to a different unit, a unit that I've never worked on before, which is a safety issue in and of itself. When I arrived on the unit, I started my shift as I would start any shift, by listening to the recorded shift change report. I wasn't too far into the report when I learned about a 2-week-old baby that was admitted overnight for observation for apnea spells, medical term used for prolonged pause in breathing. Anyone who's familiar with shift change report, at least as it was done many years ago, would know that it's common practice to listen to the report on all your patients before starting daily rounds. But in this morning, as I was getting report on this baby, I felt compelled to stop the recording and go place my eyes on him. And when I did, I was shocked and horrified to find a baby that was blue and not breathing. I intervened, and fortunately, the baby came around very quickly. As I stood cradling this baby in my arms, and as the other staff entered the room, I immediately began investigating why the infant's monitor, which was reading well below normal, did not alarm. The response I got saddens me to this day. I was informed that it was common practice on this unit to turn off all the alarms at night, so they didn't disrupt the sleep of the parents and the children. So while no harm came to this baby, it was only pure luck that saved him. The culture on this unit was not safety first. This event set in motion my departure from bedside nursing. My fear of harming a patient, along with the hopelessness I experienced in working in a facility that did not put safety first, left me in search of a new career path. Thinking back over my nursing career and in conversations with other healthcare providers, I know stories like this are all too common. So I want you to think of a similar experience where you relied on luck versus safety. And in the spirit of Canadian Patient Safety Week and in support of safety conversations, I encourage you at some point today to share your experience of luck versus safety with a friend or a trusted colleague. Next slide. I hope my presentation and story to this point has convinced you that a harm-focused approach to safety is far too narrow, and that you all agree that it's time for us to adopt a broader approach to safety. Next slide. At Healthcare Excellence Canada, we refer to this broader approach as the presence of safety. Next slide. The work that we do on the presence of safety is based on the measurement and monitoring of safety framework from Charles Vincent, Susan Burnett, and Jane Carthy from the National Health Services in the United Kingdom. The measurement and monitoring of safety framework consists of 5 dimensions: past harm, reliability, sensitivity to operations, anticipation and preparedness, and integration and learning. You will see that each domain has a question associated with it, which helps us emphasize the value and importance of inquiry when managing safety. Micah is going to go into greater detail about each one of these domains later in our presentation. But for now, I wanted to share with you some key learnings. Our work over the past several years has been a journey of uncovering the potential that this framework has and helping us achieve our mission of safer care for all. Our work has included planning and implementing a 12-month demonstration project and later an 18-month collaborative, which provided us the privilege of learning alongside healthcare improvement teams from across Canada. Next slide. Through the work with these teams, we have learned that we can bring balance to the scale. We have discovered that advancing safety needs to be a balance of preventing harm and creating safety. For example, adding curiosity, inquiry, and safety conversations into your daily practice, you can help balance the need for assurance and accountability. We can enrich our safety metrics by placing value on the intelligence gathered through listening, observing, and perceiving. We can move away from thinking about safety as a project and start viewing it as a way of thinking, acting, and responding. We can move safety into the offices of the quality and safety departments and share the responsibility for safety with everyone working and receiving care. And finally, we can move away from a rear view mirror approach to safety to one that is proactive, predictive, and inclusive of the patient and resident voice. Next slide. To further build on this idea of balancing harm prevention with creating safety, I want you to think about safety as not being a circular process, starting with harm and moving along to reliability, and so on. But imagine that safety is much like a rope made up of 5 strands. Just as this image illustrates, weaving together the 5 strands of thread creates a much stronger rope. When we weave together all 5 dimensions of safety, we have a much safer system. Next slide. We have learned a great deal from working with our Canadian teams on implementing this new approach. And I would love nothing more than to dive deeper into these learnings. However, time just does not permit. However, for the remainder of the presentation, we're going to focus on one of the most impactful learnings coming from implementing this new approach. And that is bullet point number 4 on here. The value and importance that patients, residents, and care partners have in creating safety. Next slide. In our efforts to build capacity for safety in partnership with residents, 3 key lessons emerged. Patients, residents, and their care partners are an essential, but all too often an underused defense in preventing harm. In order to tap into residents and their care partners' knowledge, wisdom, and ability to prevent harm, it requires that healthcare providers have conversations about patient safety with them. However, we've learned that healthcare providers have a really hard time talking to residents and their families about patient safety. And the last thing that we learned was that when providers did invest in safety conversations with their residents, they discovered that their perspective was quite often different from the perspective of their residents. At this point, I'm going to turn things over to Micah, who's going to share some rich learnings that came from a recent research project that explored safety, these 5 domains of safety, from the perspective of residents and their care partners. So Micah, over to you.
Thank you, Anne. Hello, everyone from Kitchener, Ontario. located on the traditional lands of the Arawandawran, Anishinaabe, and Haudenosaunee peoples. Next slide, please. What we learned from working with the measurement and monitoring framework for safety teams sparked a great deal of interest in better understanding safety through the lens of patients and their caregivers. This led to Healthcare Excellence Canada's commissioning of a research project, How Safe is Your Care? Measurement and monitoring through the eyes of patients and their caregivers. Through interviews, focus groups, and a World Cafe with patients, families, and healthcare providers, we aim to answer the question, how safe is your care? Next slide, please. It's been a real privilege to have been involved as a patient partner with the research project. In the following, I will provide a brief reiteration of each dimension of the framework and share a patient history to illustrate the dimension from the patient or care partner perspective. There are differences, as Anne has already noted, in how healthcare providers and patients perceive safety. As you listen to the accounts of patients and care partners, I ask you to think about the dimension of safety through their voices. Sometimes the safety dimension is very apparent, sometimes less so. Our hope that through this research, healthcare providers come to better understand and also appreciate patient perspectives and their contributions to safety. Next slide, please. What patients and care partners told us about safety? Among what they told us in our study was, I did not feel safe there because I did not feel heard. I didn't feel safe to express my emotions. Safety needs to be based on facts and feelings. Next slide. Past harm. Has care been safe in the past? The measurement of multiple types of harm over time to help assess whether care has been safe in the past and is becoming safer. First, let's look at how we address harm. The focus is most often on whether care has been safe in the past, the rear view mirror approach. Next slide, please. More recently, we have widened our view of harm, largely because of what patients and care partners have shared. Beyond physical harm, they cite, for example, psychological harm, harm from overtreatment, or delayed or inadequate diagnosis. Using the chat, would you please share what harms you feel receive the most attention currently and which currently do not receive attention? Let's take a moment for you to do that in the chat. Just going to read some of these out loud. Falls take priority. Wounds. Physical harm receives the most attention. Medication errors. And physical harm again. Physical harm most. Overtreatment least. Physical abuse. Physical, not enough attention. Hospital-associated functional decline. This has also come up in our work. As you already see emerging, under treatment, risk of litigation, harm when there is risk of litigation, isolation. If you wouldn't mind continuing to share those with one another, you're already seeing in the comments that I recited from the chat that they echo the point that's just been made. Psychological harm has just been added. Let's go to the next slide and focus on what patients and care partners tell us about harm. What did they tell us? We heard from a woman whose husband went to hospital twice with uncharacteristic chest pressure and pain. In her words, and I quote, both times his cardiac issue went undiagnosed. In response to his expressions of concern and pressing for answers, he was repeatedly told, it is not your heart. Your EKG is fine, it's just painful heartburn. He felt judged, he felt ashamed for being there, thinking other people needed the care more. This affected his seeking help a third time. It was dehumanizing for him, this experience, and also for me as his wife. We just kept getting, you're fine, you're just anxious. This makes patients generally hesitant to speak out again. 3 days after his last hospital visit, my husband died of a heart attack during our family vacation. End quote. Next slide. Reliability. Are our clinical systems and processes reliable? This is another dimension of safety from the framework that asks if our processes and clinical systems are reliable, assessing whether a task, process, or intervention will be done as specified. Patients and their care partners have a perspective on what reliability means to them. Next slide. One of the people we interviewed was the mother of a young adult son with a complex, recurrent, and serious health issue. She told us, and I quote, I emphasize to the care team how calming it is for Ben to hear music, and asked him to please hum or sing when entering the room or during an unpleasant procedure, as it would help him be comfortable. They put it up on the whiteboard as a note. The staff actually sang through every procedure, and each time they gave him a needle in his tummy, and the whole team sang when they took out the ventilator tube. They did this because I, his mother, told them this therapeutic intervention mattered to Ben. If they hadn't done so, then it would have been almost harmful. The fact that they consistently did this intervention was so positive for Ben and for me. End quote. A comment on this story, its relevance to reliability may not be seen the same way from a clinician's perspective. For many patients, and somebody noted this in the chat box earlier, feeling psychologically safe and or personally secure are important. And having staff consistently perform interventions to support psychological safety is critical. Staff look at clinical processes, etc., as relevant to reliability. For the patient's mother in this story, the function and positive impact of having staff sing as a calming measure reliably enabled psychologically and actually potentially also physical safety for her son. This example also speaks to the next dimension, sensitivity to operations. Next slide, please. This dimension speaks to whether care is safe today in this moment. This requires listening, seeing, perceiving, and acting on the information gathered. Next slide. What did patients and care partners tell us about sensitivity to operations? From a patient's daughter, we heard this, and I quote, the powerlessness of staff really struck me, and that they felt they had so little authority. They didn't want to cross somebody else's decision, even though there was mom's life and safety at stake. One licensed practical nurse slipped me a little piece of paper with mom's electrolytes and vitals for the day on it. She said, I don't know if I should do this, worried about crossing the line. Despite the way they operated on this unit, which was not patient and safety first, this licensed practical nurse found a way to listen and respond to my concerns and fears, end quote. Next slide. Anticipation and preparedness. Will care be safe in the future? So this is the question that it asks, whether in fact it will be safe in the future, and focuses on possible sources of future harm and how to become more resilient to them. Don't wait for things to go wrong before trying to improve safety. In this photo, on your screen, Wayne Gretzky, is evidently not best prepared. The image of him with a helmet, he isn't wearing one here, that we could have used had him wearing the LA Kings jersey. As you can see, Canadian pride won out on this example. Next slide, please. What did patients and care partners tell us about anticipation and preparedness? One patient who experienced harm told us the following, and I quote, "I probably still would approach healthcare with that same level of trust I had before, but now I do not. I bring not cynicism exactly, but a critical eye. I look at the environment and I gain a sense from the provider of their comfort and ease, their communication, their stress. I pick up cues from the start. I've done my homework and I'm prepared to have conversations at that level. I want to know how willing they are to share knowledge with me and delve a little deeper," end quote. Next slide. Integration and learning. Are we responding and improving? The development of systems to promote a cycle of learning and sharing from safety incidents, multiple sources of safety intelligence, and insights developed through the other domains. So it has us asking the question, are we improving and learning? After all, a learning system is a safer system. Next slide. What did patients and care partners tell us with respect to integration and learning? The mother of a young child with a complex health history told us, and I quote, "I created what I call an emergency room one-pager, which has all the pertinent basic information, like his date of birth, his health card, along with the description of what he is usually like, happy, content, energetic, and also what his capabilities are. I did this after his first big seizure because how he presented then was so different from his normal self, based on which we convinced the doctors to look further. It taught me to give the emergency doctors some really good basic information quickly in a matter-of-fact way. This objective piece of paper says this is who this person is, what they're like, what their normal baseline is. It's been really helpful in frequent emergency room visits and much appreciated by doctors. You really cannot make assumptions about patients based on their presentation in the moment," end quote. A comment on this story, the mother updates this one-pager and keeps it current. She uses it as a tool to create safety for herself and her son. As a living document, it comprises the integration and learning gleaned from her son's health history and care. Over to you, Anne.
Thanks, Micah. So if we could jump to the next slide. So I hope, and I'm assuming most of you have already heard that Canadian Patient Safety Week is coming up next week. The theme for the campaign this year is Press Play on Safety Conversations. This theme grew out of the work that we've done on applying this measurement and monitoring of safety framework to the care that we deliver. We know that safety conversations are one way we can all work together to create safety. They are an important step in building a positive patient safety culture. Healthcare providers, managers, and leaders need to be able to talk honestly about all of the influences on their ability to deliver safe, harm-free care. Patients, residents, and their essential care partners need to be able to feel safe to speak up about their care and what they need to feel safe. We've learned a great deal from working with our healthcare teams and applying this proactive approach to safety. And it's our hope to spread some of their ideas and innovations to you through Canadian Patient Safety Week. Next slide. So in the next little bit that we have together, it's my pleasure to be able to share with you just a small sample of some of the innovations that these teams implemented to help strengthen safety conversations in their organization and in their practice. Next slide. So the first strategy I want to share with you are patient safety huddles. And I'm sure most of you are familiar with the concept of safety huddles. But what this team did was to expand their safety huddles to include their patients. And they did this by starting to invite patients to share what safety means to them. And over time, this eventually evolved to inviting patients to submit safety tickets, which would be discussed and acted on during the safety huddles. And so when you look at the screen and you look at St. Joseph's improvement system, you can see in the far left, there's a square there that says safety cards. And so these were tickets, essentially safety issues and concerns that whether you were a staff, a nurse, allied health professional, worked for environmental services, anyone that worked and interacted on this unit had that opportunity to write a ticket in real time and drop it in this slot. And on the huddles that took place twice a week, these safety concerns would be addressed and talked about throughout the huddle. And over time, some of the patients on the unit actually became comfortable in submitting their own safety tickets, which would be discussed and acted on through the safety huddles. So if we jump to the next slide. The staff in this residential care home were struggling to talk to their residents about patient safety. So they started a poster campaign in which they invited residents and their families to fill out the poster with, "What makes you feel safe?" These posters were posted in the residence room and served as a reminder to the staff what makes that resident feel safe. And the other thing they did was that they helped stimulate conversation between staff and the residents and their families. Go to the next slide. So taking this idea, a team from the Victoria General Hospital during Canadian Patient Safety Week in 2019 asked their staff and patients and visitors that came into the facility to complete the sentence, "Blank makes me feel safe." And their comments were posted throughout the entranceway for everybody to see as they entered the facility. We could jump to the next slide. So another team from an acute care surgical unit leveraged this idea of asking, "What makes you feel safe?" But they took it one step further and asked, "What would make you feel safer?" And then the next slide. So this final strategy that I want to share with you today came from a team in a long-term care facility who co-created with their staff, residents, and their care partners a tool to help facilitate safety conversations. They recognized how difficult it was to start safety conversations. So essentially they came up with safety conversation starters. You'll see from the slide that the tool they created starts with rapport building questions and slowly builds towards deeper conversation starters, such as, "One question I've been afraid to ask is, I feel safe when? I would feel safer if." Next slide. So as part of Canadian Patient Safety Week, we want to invite you to start safety conversations in your organization and practice. So one way you can do this is you can download the "What Makes You Feel Safe" posters and invite your staff, residents, and care partners to comment in the box. And we will post in the chat box the link to this page, the site, or if you type in the web address, safetyconversations.ca. That will take you to our Canadian Patient Safety Week website pages. So if we jump to the next slide, I want to share with you some details about a webinar that we're going to be hosting on October 25th. This is going to be a panel discussion where you'll have the opportunity to hear from a healthcare leader, a provider, and an essential care partner that were all part of our work with healthcare teams on approaching safety through a broader, more holistic approach. And through this webinar, they are going to share with you how they approached safety conversations and how their safety conversations helped enhance the safety culture where they were working and experiencing care. And the next slide. So this is the last opportunity I want to share with you, and it is called the Safety Conversations Action Series. So an action series is a mini collaborative. And essentially what we're going to be doing over a 4-month period is helping teams that enroll in the action series strengthen their safety conversations. And through this action series, enrolled teams are going to have access to a team of faculty and coaches. And throughout the series, we'll be delivering content through webinars. And in between the webinars, the teams will have access to the coaches that are going to really help strengthen and move you along in your journey towards safety conversations. And we're working on getting registration open, which we hope will be open either later today or tomorrow. But once again, the link is on this slide, safetyconversations.ca, and you should be able to find out more details about the action series and how you can go about registering. So the next slide. So this is my cue to stop, open up the conversation for questions, and you'll just see, just because I love this work and want to share our experience, you'll see some resources. So if you want to learn more, I invite you to go to our website and look up Presence of Safety. More details about the research report you'll find there, and then also the link to resources for Canadian Patient Safety Week. So with that, Andrea, I will pause and we'll take some questions.
Thank you so much, Anne and Micah. I can tell from the chat that there's a lot of interest and engagement in moving into action. So there was a lot of resources that were shared already. Folks can start with the safetyconversations.ca website. So that's a great place to just sort of make a pledge in terms of taking action and learning more, getting access to tools, things that you can reflect on to start to think about, how actions can be transformed in your own organizations, and really what's the greatest need? Where's the place that would be most meaningful to get started? As well, the safety action series that Anne mentioned, looking for organizations that really want to take it to the next level and want some coaching and support. So you're not just trying to fumble through this, on your own and while you're doing something new that you feel is really important. And that sort of leads into one of the questions that came in through the chat, Anne, which is that there's a desire to speak up. We want patients, we want our residents, we want everybody to feel comfortable speaking up. We have tools, we have posters, we have things that people can engage with, but how do you break the ice? Like when people just don't yet have that feeling that it's safe, that it's okay to do this, how do you break through that initial, sort of
Fear.
Static inertia, that's right, that fear of like, okay, but we don't do this in our organization, so then how do I just start doing this?
Yeah.
You have some thoughts on just breaking that awkward ice and that first step to get through the fear?
Yeah, and I'd say that fear is common. When we worked with our teams and we sent them out after the first learning session with what we thought was going to be a fairly simple action of go talk to your residents, talk to 5 residents and talk to 5 colleagues about safety. And when we followed up on our site visit and we recognized how difficult this was, and we heard from the teams how much they struggled, there was so much fear around this, fear of like opening Pandora's box and like overwhelming problems were gonna, just fall on people's laps. Those are the sorts of things that we heard. So there's no one simple answer. I think part of it is creating a space where it's psychologically safe for people to feel safe to speak up. And that doesn't happen overnight. It comes through what I'd say small baby steps. And I'd say some of those baby steps is really just starting that conversation, asking the question like we did in the posters, what makes you feel safe? Keeping it light and open for people just to start. And from that, see where the conversation goes. The conversation starters that came from our colleagues at a long-term care facility that they co-created with patients and essential care partners, like that idea of building some rapport and then slowly building towards the safety conversations. Some of the things we've heard that does not work is yes, no questions. If you ask, do you feel safe? Chances are you're not going to get a meaningful answer. You'll probably just get a yes. So part of that is finding a way to ask questions that makes it easy for your residents and their care partners to answer. And another strategy that some of our residential care homes used was they built questions right into their monthly assessments that they did the family conferences. And in order to help prepare the families for those, they sent information out ahead of time to let them, the families understand a little bit more about what safety was and that we were looking at safety beyond just physical harm. And then during those safety conferences, they started that dialogue around what do you need to feel safe? What do you need to help your loved one or your family member in our care to feel safe? So those were a couple of strategies. Micah, I'll pause and see if you want to add on to that.
Yeah, two thoughts. One is that, as we all know, the healthcare system is under great, great pressure. And so I can imagine, and in fact, I've heard this from health professional friends, that time to have meaningful conversation is at a premium for many. I think this is where, instead of thinking as creating safety and ensuring the presence of safety as a layer on top of an already pressured circumstance, it's really important, I think, to focus and on developing greater awareness and understanding of the role that patients and their care partners can play in that, and to forge partnerships. And I realize that's not possible or realistic for all patients for any number of reasons. But I think if we start there to understand how integral patients and essential care partners are in the creation of safety, and I think some of the stories served hopefully to illustrate how that can happen.
Absolutely. There's sort of two different threads coming in that I want to make sure we have time for, because I think they're really important. One is building off a comment that was put forth by Cheryl around, overcoming the obstacle where maybe administration's not ready to receive feedback about, errors in the care process, and not being willing to follow up directly with patients and residents. And in your experiences, have you found strategies to overcome, this lack of readiness at the administrative level?
I can jump in, and I think from my experience and looking back to those safety huddles that took place, where you brought safety to the front lines, recognizing that care delivery, safe care delivery happens in that interaction between a patient, resident, and the staff member. And really bringing it back to listening, observing, perceiving, seeing, and then acting on what you're hearing. And so what would take place during these huddles that we had was that empowerment of staff to speak openly about what they were seeing and to really together co-create some strategies that could work towards creating that safer care. So that idea of not relying solely on managers and administrators to solve the problems, but recognizing that healthcare providers, for the most part, have answers, solutions, and strategies. towards creating safer care. Now, absolutely, there's going to be times and things that we need managers and administration to help with. But I'd say the more we can bring it back into the hands of those delivering care and really tap into the wisdom that they have and the knowledge and the desire that they have to create safe care, we can advance a lot.
Thanks, Anne. Micah, would you like to add anything to that?
No, I think I'll let Anne's comments stand there. I'm intrigued by a question in the chat box, but perhaps I'll leave that to you, Andrea, to address.
No, you're leading us exactly where we were going to go next, which was Marilyn's comment around the stigma associated with addictions and mental health and what is being done to address the health inequities in our long-term care and community care settings. And just sort of tying that back to creating, a space that is safe for all.
So, Micah, do you want to take a stab at answering that one first?
No, why don't you lead that, Anne? You're
Sure.
more knowledgeable.
As I've said, like, none of this is easy work. It is really, really difficult, and there's no magic bullet, unfortunately. So I'd say, some of the things that we can do to start address some of the stigma within the world of patient safety is, if you think back to that slide where Micah was sharing about the expanded view of what safety and harm, what harm is. And the more we can start to move outside of the box of thinking safety is just physical harm and start to really appreciate and internalize that safety is also providing psychological safety, helping to reduce harms that come from things like dehumanization and racism. So back to some of those very, very simple things around having some conversations, creating that safe space where it's comfortable and safe for people to kind of speak up about what doesn't feel right for them. And once again, co-creating some strategies and solutions in terms of how as a group we want to address and move forward. There's no one, like I said, magic bullet, and there's no one answer that's going to fit right across the entire health system. So I encourage you to go back and talk to the people that are delivering the care and those receiving the care. Look to them for what's going to work, what might work, what do we want to try today, and what can we try tomorrow.
Thanks, Anne. I mean, what I'm hearing is this is really culture change, right? Like this is really changing the way across the organization we think about safety. Again, not just the absence of harm, but safety, in terms of the presence of safety, but also psychological safety, physical safety, reliability, all of those different dimensions that Micah illustrated with those beautiful examples. And how do you get that broad view of safety in order to pick up on all the opportunities to make our residents and our patients feel safe and experience safety? And, we've had conversations around board to ward, like how do we embed this at every level of the system, and it takes time. So again, just bringing it back to this opportunity that's on the table with the action series and some coaching and support in order to help look across the levels of your system and looking for opportunities to take something really tangible, really actionable, a safety conversation, and then find ways of weaving that into the processes and the tools for quality and safety in your organizations to get that culture change. We are welcoming one or two more questions before we close out the webinar. So if you have another question, by all means, please post it in the chat. We have a few comments here as well that we can also frame into some questions for discussion. One of them, again, talking about communication difficulties. And this, I can see this even more so in our long-term care settings where, people are often wrongfully identified as incapable and they're shut out of care decisions. We don't bring them into this process. We have healthcare workers that might not take the time to communicate diagnoses or interventions directly to the individual, but also thinking in terms of these safety conversations and when there are communication challenges, how do we ensure that there's inclusivity and that we're creating an experience where we can learn about what makes everyone feel safe, even when there's communication challenges. And have you had any experiences in any of the programs that you've done where people have used, interesting or adaptive, instruments or approaches so that that people could express themselves, that what is safe for them can really be heard and understood by staff.
One creative idea that comes to mind was one of our long-term care facilities recognized that the culture on their unit was not for people to feel safe to speak up. So they took a walker and they created the walker, changed the walker in a decorative manner into a safety booth. And so this booth went around from unit to unit, and staff had the opportunity in a manner that wouldn't identify who was putting forward the issue or concern, but to drop into the envelope their concerns about safety and their ideas of what could be done to help create safety. So that was a fun, creative way where the manager really showed and demonstrated that she wanted to hear, and she created that safe space for people to speak up. So not only did she invite them to speak up, but she made it safe for them to do so. And then of course they went through all of that information over time and discussed it as a group at a safety huddle. So it's not only about asking for feedback, but it's closing the loop, having meaningful dialogue about it, and of course taking action on what you're hearing.
Thank you. That's a great example. Yeah, and I'm seeing a comment here, on the gratitude for the richness of the comments and the experiences that you've shared today, both from yourselves personally, as well as, folks that you've had the pleasure of learning and growing with along the way in this journey of the presence of safety. So wishing you the very best in your upcoming action series, hoping that it connects with many of you in our audience, and that you're able to take advantage of the opportunities coming up. Thanks to all of you for joining us today. It's been a pleasure to have you on our webinar. We have a poll that's just been posted, so please, if you don't mind taking the time to respond to those questions, it helps us to build our programs as we move forward, making them the most relevant that we can for you. Which, on that note, again, just reminding you that HEC is launching our next phase of programming to support long-term care homes. So this program is going to support the improvement work focused on people in the workforce and person-centered care. It aims to contribute towards a more resilient long-term care sector. So the program is going to be running for 1 year, from January to December of 2023. And in this program, long-term care homes in Canada are invited to apply and will receive support for improvement work focused on people in the workforce and person-centered care, including funding of up to $10,000 per home and implementation and capacity building support, such as coaching and monthly webinars. For more information, you can visit healthcareexcellence.ca, and where you can also watch a recording of an informational webinar on the program, and you can apply to join by November 4th of this year. As this webinar series is officially coming to an end, we'd like to invite you to register online to rejoin the next iteration of this monthly webinar series, which is open to the public. The first webinar in our new series will start on January 24th, 2023, and it's going to feature, for the first one, updates from the Health Standards Organization on the new National Long-Term Care Services Standard. So please register for the new series using the link in our chat box or on our website. And again, thank you very much to our speakers for excellent and engaging presentations. Thanks to all of you for your comments and questions. I hope you found this informative and that you enjoy the rest of your week. Thank you again. Have a great day.